seal around that membrane. So 1 week post-op, no surprise, as this is a bioactive barrier membrane rich in growth factors, that we're going to get that rapid, or that accelerated early healing that we desire, and I see quite often in patients that I use BioXclude with. Subsequent good healing at 4 months out as the tissue remodels. And here is a video at re-entry. And this is not anything crazy like what Israel was showing, like growing mounds and mounds of bone, but I want to show the bread and butter of my practice, what you do on a daily basis. It's, it's beyond just doing one case very well. It's important to have that consistency over time, and that's what I can get in using this biomaterial. It makes it for a very easy surgery to get that implant in a desirable, restorable position, and straightforward as it can be. So as I got more and more comfortable with using this biomaterial, okay, I went ahead and felt more comfortable in this tooth that cannot be saved due to a vertical root fracture, doing it the way I typically do with every patient I have the chance to do it, is minimally invasive, flapless procedure when possible, tooth taken out, and got my particulate bone graft in place, and just one reverse figure 8 suture in place right here. And the beauty of this is that this membrane, you can see, is still intact 4 days out. I was fortunate to have this patient be able to come back earlier. And you can still see it's intact. It has antimicrobial properties that I'll soon discuss. And we get great healing 4 months out. And at re-entry, again, I like my procedures to be straightforward and easy, be predictable over and over and over again. But what I want to focus on is this right here, is that I like a biomaterial that I could leave intentionally exposed so I don't have to distort the mucogingival junction, as Matt Fien always calls it. I don't want to create that self-inflicted mucogingival defect. And I'm not perfect. You're going to see some of my complications later. If I have a biomaterial that offers me, a little bit more leeway in case I get that accidental exposure. I mean, we've seen with studies and what you see in the agar plates here where they have various biomaterials, you'll see that BioXclude is the one that has a zone of inhibition, not just around a disc, but at a distance away from where the BioXclude disc is. And I think that's really, really nice to have, knowing that we all know the mouth's not a clean place and a lot of bacteria in it.
So this is, and I'm going to touch on a little bit of the stuff he just did, but this is the first case I did. And the reason I elected to do this was I had been looking for something to help me when I'm doing socket preservation mainly, that I can leave exposed and I'm not going to worry about the top of the graft not turning over. I wanted something that, one, I didn't have to remove. I'm not a fan of the PTFE removable stuff. I don't like having to go back and take something out. And I was looking for something better than what I was already using. So this was after actually talking to some of the guys up here about who had already started using this. This was the first case that I chose to do it on. So you can see there's at least 5 or 6 millimeters of the material in the graft exposed. This is at about a week. You can still see the film of the material is still there. The graft is still kind of coagulated together. And this is what I see on the majority of my early healing of these cases. And this is what I see at about 2 months. And what I love about this is the amount of keratinized tissue that I see and how well the epithelium has kind of grown over. And this is very, very consistent with this material. And I attribute that to, like he was just talking about, to the antimicrobial factors, as well as the immunomodulatory factors. And then with the bone growth, I'm relying on a lot of the growth factors that are helping out. But this is what got me into using this material. But I'm going to talk about a case that's a little bit more advanced, stuff that we see all the time in our practices. This was a failing root canal, fractured root, where we had a big abscess and we had loss of almost the entire buccal plate to the apex of the socket. So here it is, an initial presentation. You can see there's an abscess on the buccal there of number 19. When the tooth was taken out, there's quite a large defect, not something that I'm comfortable placing an immediate implant in, but this is something that I want to regenerate and rebuild, and ideally without trying to do too much, right? I don't want to use any kind of autogenous plates or titanium, stuff like that. I want to try to treat this like a socket preservation, knowing that I have to rebuild a lot more bone. So I placed some allograft particulate. I placed my BioXclude membrane over top it, and this is a little video that John put in that just shows how easy it is to place. So you could tuck it in, it's placed dry like he just mentioned. I do like when you have a wet area with bleeding, it does start to kind of drape and stick to the area. So you can see it here with a little flap. It's very easy to tuck in, and then without even adding saline, it starts to kind of stick. Now, if you want to have this conform a little more, you can add some saline. I do find that when you use your instruments to tuck it in, having the instruments a little bit wet prevents the membrane from sticking to them. That's always a nice little tip. And then with this particular case, because of how big the defect was, I tried to advance it a little bit to get as close to primary closure as I could, understanding that when I'm going to go back and place my implant, I'm going to try to reposition that. So I put in a horizontal mattress suture, and then I got pretty much the primary closure over this with glycolon sutures. And here it is about 4 months, which is really on the earlier side for something like this, at least in my opinion. But I really loved how this was looking at 4 months. So we decided took a CT scan, obviously. But you can see what's very impressive about this x-ray to me was that it looks like I've already started to regenerate the cortical plate here, which is kind of a surprise, but this was very, very pleasant for me to see. This is the tissue healing. It was after I numbed, so that's why it's a little bit white, but you can see how thick and broad that band of keratinized tissue is over the top, over the crest. And this was the implant placed at 4 months. I went back in at 2 months. I did bury the implant. I just tend to do that a lot. I went back in and I flapped it, and you could see that there was bone already covering part of the crestal portion of the implant, but you can appreciate how good the bone on the buccal and lingual look, especially the buccal where there was no bone at all. And then here's an image of a CT scan after this was uncovered. I placed a custom healing abutment, which you'll see here. I do these for the majority of my cases. And then you could see it a couple weeks afterwards, and you see how good the tissue and how thick the tissue looks. And then just here's the before and afterwards. So this, for me, trying to enhance the usage of this material to see how far I could extend it, I started getting more comfortable with using this membrane to try to regenerate more than I had originally started with just regular socket preservation. All right, so next, John, go ahead.
So, as I mentioned earlier, immediacy is big out there. I mean, there are not many patients out there, if you ask them how many surgeries you want to have it done, 1 or 2, are they going to raise their hand and say 2? We're going to want to get it done in 1 surgery if possible. And so we're going to shift gears and do immediate implants here. Got a tooth with a resorption lesion that can no longer be saved, and went ahead and removed it. You can see the lesion there, another angle of it, and proceed as I normally do every day in the office here, making sure I get that implant in the desirable restorative position. There was a slight loss of the buccal, and so I didn't hesitate to raise a flap, even though I try to keep things minimally invasive, as I wanted not only to graft the gap, but to also address the buccal plate. And as I always will graft the gap, and I'll do it with the particulate that I feel comfortable using for that case, and I'll bring out the smiley face that brings me a lot of smiles, known as BioXclude. I thought that'd make you laugh, Brad. And this is what I like a lot about BioXclude, is that I like to use things that are easy to use in my hand. And again, it's one of those things, like most things in life, you got to practice makes perfect. You got to give it a chance, because it handles different than other membranes out there. And you don't have to worry if this is touching an adjacent root. You don't have to worry if this folds upon itself, okay? Because the epithelium's taken off from both the amnion and the chorion layer, and then that's laminated together. Here it is, BioXclude. It drapes very well. When you bring it over dry, and it will suck down right onto the bleeding site. And again, very, very easy to use. Got close to primary closure. I'm not going to fight it. I'm not going to even worry about it. okay, because BioXclude can be left intentionally exposed. 1 week out, see the good healing, lack of inflammation, no complications. And here we are at re-entry. And this is where we were before. And it's like one of those WTF moments. What are you guys thinking? I'm thinking, where's the fixture? Okay? Like Matt said earlier, the stud finder. Okay? This is a good problem to have when you have to spend a couple extra minutes unearthing that implant. So if I have that WTF go off, and for this reason, I'm a happy guy. I usually start off with high speed, a handpiece, and then follow up with a back action chisel. And there it is from beginning to end. Straightforward. I typically don't like to deliver crowns, but yeah, if you worked with this dentist, you would know why. And so lab bails me out, got the implant in, got good peri-implant soft tissue health. Very straightforward.
All right, so there's two other cases that we'll show with this before we get to the peri-implantitis stuff. This is my favorite use for this particular product. I believe Curry showed it earlier with repairing of during lateral walls. If you have a perforation, it is a fantastic material to use where you can kind of grab one side of the tear with the material and it sticks to it, and you can kind of close the tear, and it works really, really well. This is going to be more targeted at a more direct or crestal approach. We all do this. Whatever drills you use or osteotomes or balloons or whatever you use, we can get tears, right? Membranes can be thin, we can get tears. I use this even when I don't have a tear to act kind of as a little protective barrier, but this is the way that I use it. So here you can see the osteotomy site starting. I have a couple instruments that I use that will help push that membrane up. So Matt, you're gonna like this. I'll use this instrument to kind of push up the membrane. So little backstory, when I did residency with Matt, Matt was like the PowerPoint like genius. And he would have slides doing things and we were just like, where did this come from? So when setting up for this, I was like, I have to have something in here that I can at least, he can like kind of like be proud of. So I use these instruments to push the sinus up if there's a small tear or if there's no tear. I still will put this membrane in. And there's a couple ways I do it, but this is the main way that I put it in. I will tuck it in a little bit. I will put a biologic or a bone material. This happens to be a collagen, like a BioOS or Salvinos collagen that I use. I place it in, and then I'll push this with the BioXclude membrane in, and it'll push up, and you can see here, pretty intact. And I took a CT scan after, so this is before, and this is the same day, and you can just see how well it moved that up. So I really, really like this product when there are small perforations because it sticks to and kind of blocks those perforations so you can still graft. Whether you use particulate or not, doesn't matter. It still works really, really well.
I will say that's a cool instrument. I use it too.
Yeah, I forget where it's made by, but it's a fantastic little instrument.
I call it the mushroom.
Yeah, it's pretty much the only one I use for those, and then yeah, it's really great. Here is a really cool case that I did recently. Patient presented with an avulse number 9, very large alveolar defect, as you can see here on the 3D model. And this is, I decided to push the envelope. Now, a lot of us will graft this first, and that's probably the smarter way to do this, but I wanted to push the envelope on this. I placed the implant. It was within the confines of the defect. So I went ahead and decided that I was gonna place the implant and I was gonna do a graft. Now here, I did a veneer graft with the xenograft. I don't use a lot of xenograft. But in this particular case for volume, I decided I was gonna use my allograft around the actual implant and then put a little veneer of xenograft on top. We talked about this earlier. With GBRs where I'm gonna get primary closure, I like to use this membrane directly on the bone. The reason I like to do that is I'm throwing all the growth factors onto the bone graft. And more importantly, I love how it kind of grabs and confines and holds the graft in place. It's kind of like a sticky saran wrap. So I don't know about you guys, we talked about it earlier. Do you guys tend to put it on the outside, on the inside? Do you kind of hit or miss with it?
No, I like the way I like the way you use it. I mean, I think if you add the growth factors to the bone graft in itself, without any collagen membrane over the top of that, you get basically double benefit, right? Benefits within the soft tissue,
Right.
exclusion, and then benefits within your graft. So this is great about this membrane.
Right, so now with that said, I am going to add another membrane. I'm glad that you spoke because I owe you from earlier. And this one, because of the amount of grafting I wanted to do, I did want to add a second membrane, so I have a cross-link membrane here. And then I have, like Israel was talking about earlier, I use 6-O-glycolon sutures or long-lasting resorbable sutures with periosteobites. And sometimes I will put horizontal ones grabbing the bound-down tissue outside of the flap to just extra stabilization. And then I got primary closure. This wants to go. I got primary closure here. I'm going to show you the before and afterwards. Like somebody, I think John just mentioned, there's some times where I don't take pictures of final restorations because I'm just so angry at what I see. I'm sure you guys all have that, so you're not going to get a picture of the final restoration. But this is the final result with the restorative part, or with the regeneration, which I was very, very happy with, and almost surprised. So this was, I attribute to a lot of the, I attribute a lot of the regeneration for this case to the growth factors that membrane added to it. And this is because I use the other membrane a lot as well, and I don't think I would have gotten the same amount of regeneration without this particular membrane.
Wow, that's a nice bulge. I was talking about the bone up there.
I'm gone. I'm done.
Okay. Let's talk about something that we see more often than we would like to. And look at the numbers up here. Is this something you agree or disagree with? I mean, I'm getting more and more referrals on a daily basis on implant complications. And I'm not saying that I don't have my own. You will see soon. But peri-implantitis is a real thing out there, and we got to be able to manage these complications if we want to continue to have implant therapy to be as popular as it is. So in the world of social media, I believe, whether it's professional or personal, it's really easy to get insecure, because often you'll look at someone's account and it's like someone's ESPN highlight reel. Every case is perfect and beautiful. And even when they have a failing implant, you always see #this is not my implant. And truth be told, this one is not mine. It might be Curry's, just joking. But this is not mine, and I'm going to help manage this. And I want to go through what has worked really well for me in treating peri-implantitis here. You can see the exudate coming out, the inflammation on the palatal, and the bone loss, very evident on the PA. Only thing I like about treating these is that it's so easy to remove all that granulation tissue in a few swipes. And I really like to use my Acteon Neutron implant tips. And this is probably what I spend the most time doing in doing these procedures, is the decontamination. Because if this is not done well, it doesn't matter what you do. I just don't believe it's going to work out. So after even using those Neutron tips, what I'll do is I'll go ahead and get my titanium roto brush, and I'll go circumferentially around that implant over and over and over again, and you'll see that that titanium roto brush, it gets frayed. I'll then go ahead and proceed and put my doxy slurry, okay? And so there, that's the doxycycline. Just put a little saline in it. You make your doxy slurry. And what's actually pretty neat is that, and Matt Fien talked about this earlier when we were in our first lecture talk, is that there's a study out there showing that the BioXclude, with its inherent antimicrobial properties, can be just as effective as tetracycline. And so I'd like to have as much as I can to help decontaminate this to give every chance in saving this implant. Go ahead and pack in my particulate bone and get the BioXclude out. And I know what we said earlier. I mean, a big benefit of the BioXclude is how easy it is to use and no need to trim. But in this case, I got the 15 by 25 and a 15 by 20, and I went ahead and trimmed accordingly so I could have one layer on the facial, one layer on the palatal, and the other two interproximally. Remember, if you were in our first talk, it's hard to get it interproximally, and that's a benefit you get with BioXclude, because GTRs, in my opinion, are still a lot harder than GBRs. And that's where BioXclude has really made my life a lot easier. So the BioXclude draped really well around the bone graft and extended onto native bone. Get your closure and see good soft tissue healing. And so here we are 14 months out. I promise I was probing as hard as I could and got good probing depths and good bone fill. But what I like most about this is what I see on the CT scan, considering where we started. Is this going to happen every time? No, but I'd like to give myself a chance, and that's what BioXclude really has done when you're using the proper surgical technique. As a control freak, I like to control as much as I can, and what I understand or realize is that the only thing I really can control is my techniques and what biomaterials I use.
So, like he said, we as periodontists, with today's day and age where implants are so prevalent in every practice, we want to use materials that not just can establish that foundation that's going to minimize the chances of our implants that we're placing, minimize the chances they're going to have problems, but we also really have to know how to fix these or repair these, because I don't know, I'm sure like most of you, we're seeing more and more cases that are either our own or from other people, because a lot of, let's just say, not sufficiently trained people are doing implants. Anyone can do them now. And we have to be able to treat these, because that's becoming more and more of who we are and what we have to address in our practices. I work with my dad, who's been doing implants since 1990, and I see things that are his, I see things that are other people's, and there's going to be problems with implants we place now that are perfect. It's going to happen. And so having the availability of different materials that can give us a one-up or give us a chance of doing that, and sometimes it's cases that, you place an implant on somebody and they come back at 6 months and there's already some kind of defect. The question is, when do we take them out? When do we try to fix them? And sometimes we have to fix them because people just want them to be fixed. This is a case from Israel, and I feel like this is a very kind of common thing to see in the anterior, where someone comes in with an implant with a fistula, and you may take a CT scan and be kind of unsure if there's a little bit of buccal bone or not. Obviously, there's an issue going on, so he's got to flap it. When he flaps it, he says, what am I going to do, right? Am I going to add tissue? Am I going to add bone graft? So Israel, if you want to chime in at any point, please. He cleans it up the same way John just did with the titanium brush. Did you do anything else? Do you do any kind of medicinal stuff, or you just kind of clean physically, or it just depends on each case?
Yeah, I mean, there are times that I've used Prep Gel.
Mm-hmm. That's what I use. Yeah.
UTA.
Mm-hmm.
And, sorry, this is not on. There are times that I've used Prep Gel or not, and in this case, I don't think that I did. I just went with a titanium brush and really cleaned the surface of the implant. And that's all it was. It's just cleaning of the surface of the implant. And all these cases are really just about, deciding with the patient, again, like, what do they want? Do they want to give it one last chance? Like, because in my hands, I can't predictably say that we can regenerate this. Mm-hmm. So I honestly, I'm very much of, if we can't predictably do something, I let the patient decide, and then they own the situation and they understand if it doesn't work, it's their decision, and they're not upset with us. And so in a situation like this, like, do you want to give it one last chance to try to save this implant, or do you want to remove it and start over and leave it up to them?
And we also know that sometimes removing implants, if we can't reverse them out, can be quite traumatic to the bone. And in the anterior area, that can become a very big problem, right? So he went ahead and treated this with, I believe this is allograft mixed with PRF to form sticky bone.
Yep.
Placed our BioXclude membrane, and you can see here how nicely it just kind of sucks down on top of that. Then he went ahead and placed some PRF. You can see this here at the immediate follow-up with glycolon sutures. I don't know, I'm not sure how far out this was. I think this is a couple months maybe.
I don't remember specifically, but I would imagine it being about 3-4 months.
You can see how nicely the soft tissue is healed. And this is, I think, extremely impressive.
Nice.
This image shows so much where he was able to regenerate all the way to essentially the apical portion of this implant, how much bone he was able to regrow. And because of the use of the materials he incorporated.
There's a great course in Photoshop I can teach you later.
Okay. And then John, we finish it up with this case?
Yes. So I'm going to go over to this case on Susan, and I'll own this. This is hashtag this is my implant, and this hashtag WTF, the original meaning. I took out the tooth 2014, placed the implant same year. Was doing well, and I wish I could blame the patient on this, but I mean, she's committed. I think she comes in for cleanings every 2 months, excellent oral hygiene, no medical health issues, doesn't smoke. But yet, we have peri-implantitis, and I'm not too happy here. It's something that I'm invested to as well, and I don't think it could have been said any better the way Israel said it, but we both decided together that we are going to give this a chance. And this case is very similar to how I treated the prior case you saw. Don't change anything. Degranulate, and I want to clean that out, but you could appreciate a significant defect almost around the whole implant except for on the lingual. And I'm a creature of habit, do it the same exact way, and I spend, again, the majority of my time in the decontamination process. Even put a little EDTA. I think I skipped it. And then I want it spiffy clean as it can be. Some of the markings you see in there are from Leavitt done in the past that did not work out as well as I'd like it to. Got my doxy slurry, as I mentioned earlier, and put my bone graft in. The only thing that I did here differently than I did last time is that as much as I love BioXclude, I mean, for those who have already used it, it is a little thinner, and so I want to be able to maintain that space a little bit better. And I also would like to have something with perhaps a longer barrier function, which is why I incorporated this membrane. Get it in place, and lay a BioXclude over it. And we already talked about this earlier. The rationales that were mentioned earlier makes every bit of sense to me, and I've used this membrane enough under, over, and both over, under the collagen membrane, and to be quite honest, I just have not seen a difference in my own results.
I like this though. I like the way for an implant where the other type of membrane is not going to really hug around and create kind of like a seal around the implant and the graft. So I like that you placed the other membrane first to provide space maintenance because he's trying to grow vertical. This case is crazy to me. But placing that BioXclude on top kind of can act almost like a seal around the neck of the implant as well. And I think with peri-implantitis stuff, as much as we can get sealed off and excluded from the oral cavity is very beneficial. So in this kind of case, I really like the way that he did this.
Thanks. I mean, good points you bring up there. 1 week out, again, what I typically expect in using this bioactive barrier membrane. Remember, it's a carrier of growth factors and a barrier membrane in one. And 3 weeks out, all the sutures removed, tissue looking good. Still holding my breath. I mean, I want to see how this heals over time. But one thing I will do is I'll gently palpate the area and push around it to see if any exudate comes out, and I'm just praying it doesn't. 3 months out, nice pink tissue lacking inflammation. Or is that, sorry, 8 months out, my bad. And here's the timeline, I tried laser therapy at first. I might have had a little success. I gained back a little bit of bone. But it wasn't enough, and there was still pus, bleeding on probing, tenderness in the area. which is why I tried to rescue this implant. And great probing depths. And as this patient is, a kind neighbor of mine, she agreed to do a CT with MAR, metal artifact reduction, to see what we had before and after. And this is what I thought was pretty neat, because I'm not going to open up the area for the sake of a presentation or to verify if I got good bone. But if you look at the 3D rendering on the left and also the CT scan on the right from the pre-op to the 8-month difference, I mean, this is something that I think, again, using the right biomaterial, having the right surgical techniques, and honestly some luck, we can hopefully save some of our implants. Yep.
When you compare the cost of the drip procedure and the BioXclude DDR procedure with taking out the implant and starting over, how does that compare financially?
Well, in that case, it didn't really play a role. When I get a patient as compliant as she is, I'm going to try to help her out. That was an implant I placed. Now, it's different when it's from a patient where I did not place the implant myself, and that's not to punish them, but I feel like I shouldn't have to own every problem. Yes, we do go through a cost breakdown of what it would cost to perhaps save it or start over. And in those cases, I really emphasize, no matter how hard I try, I mean, to me, treating peri-implantitis, even though you're seeing some of these cases, it's still unpredictable. It's pretty hard. So I give them the harsh reality of what it will cost if what I attempt doesn't work. And like Israel said it before, I love that. It's just like, let the patient make that decision. Mm-hmm. After you inform he or she of everything, let them make that decision and, just give it your best shot.
Yeah, sometimes, I see it quite frequently where someone will not want to have an implant taken out and they want me to try, even if I think it's a completely hopeless cause. And I'm sure all of us have had this. Can you try to save it? Can you try to save this tooth? Can you try to save this? I spent $5,000 on this. Can you try to help me fix this? Even if it's going to cost a little bit. Sometimes it's worth trying. Sometimes it's not. And so, this has to be in our bag. We have to know how to treat this the same way we have to know how to treat teeth that have defects. We're done. Thanks, everyone. Any questions or anything like that? Yeah.
When you place the collagen membrane, did you tack the membrane before placing the BioXclude?
I didn't tack it. Stabilization is a key for a lot of procedures, but you got to look at the defect itself and also see if that membrane is even tackable to begin with. But I didn't feel the need to do it with this.
I've done it both ways.
Like the interproximal sides of the membrane. So you place the BioXclude over it, and it adapts as well?
It does, very easily. So the collagen membrane, as you saw, was contoured, trimmed, so that it could, really wrap around the implant the best it could. But no matter how good you are with that, it's not going to be completely snug, which was sort of my rationale for also adding, the BioXclude, which, I put a couple, it could really get snug around it.
One thing with the suturing, since you mentioned, I have found because the membrane is sticky-ish, I like to, in that kind of case, I'll suture down the collagen membrane first, and then I like to lay the BioXclude on top, because if you are running the suture and it grabs the membrane, it can move it, which is just annoying. But you can also tuck it underneath, so I can suture the collagen, and then I can actually put the BioXclude and just use instruments to tuck it underneath the sutures that are already in. So that's how I like to use it. Any other questions? Yeah.
In your case, you were very close to the inferior nerve, and if you had to remove the implant, it would have been very complicated to try to get another implant in the side.
And that's why I'm happy it's his case.
Yep,
Yes.
that's a good point. Oh no, Doc. Dr. Romanos. Yes.
Now that the material is fantastic. From my personal experience, and I have PhD done on this topic, we can maybe talk about that in a separate moment. But my concern, if I can say that, is if everything works very well in 1 year, or maybe earlier than in 10 months, I don't know, this is the latest radiograph you have.
It is the latest one, and
Okay, I understand. Let's say in 10 months, in 1 year, it breaks down. Have you thought about aspects of loading, overloading of these implants? Overloading, how is the occlusion of these patients? My concern is that this is not clear peri-implantitis, but this is peri-implantitis associated with overloading, and then the breakdown occurs because not of the bacteria primarily, but also because of the soft bone that they see here in the CBCT.
I agree with you. And whenever I treat any of these cases, even GTRs, I mean, I will take the occlusal forces off of that tooth, yes, completely. But that's a great point.
Very, very important because the overloading or the high forces can accelerate bone formation. Could be also the opposite at the end. And then you show the radiograph says the BioXclude that didn't work, but I'm sorry, I don't believe the BioXclude didn't work. Maybe something else is there that was the factor of the bone loss. Just a thought.
I agree.
Yes.
Good point.
But I think you had a question first. Yeah, go ahead.
Yeah. Have you ever done any implantoplasty when you're kind of managing these cases, or is it strictly just trying to provide the best you can?
You want to answer or you want me?
So you asked, do we do any implantoplasty is what you asked, right? I don't like to do the plasty on the surface unless I'm not trying to, if I'm trying to regenerate, I don't. If I'm not trying to regenerate, if it's to be left exposed to tissue, then I do because it's smoother on the tissue. So a case where, I guess like this, where I would, if I was trying to, I would treat it by all the things that you saw, cleaning it, debriding it. I would definitely put some kind of pref gel, EDTA, whether it's some kind to try to decontaminate it, and then graft it. But if it's a supracrustal with a part of where I'm not going to be able to grow anything, then I will smooth so that the exposed parts of the tissue heals better.
That's a good point. I mean, if it's going to be exposed, you could consider it, but there are some studies out there that talk about, when the titanium can elicit an inflammatory reaction, and so, I mean, like Brad said, I would just do it if it's supragingival.
Basically turning that part of the implant into like a tissue level implant. There was one more in the back. No? Any more questions? Did you have one? I thought, no? Okay.
The front?
Go ahead.
How predictable would you say this is? And what percent of the time do you get a result that you and the patient are both happy with these expenses?
Like this? I called him and I was like, I WTF'd him. I was like, what is this? Like, how did you get this? This, I think, is remarkable.
I said luck was involved in the end. Luck and prayer.
I think a lot of the other cases where you have more of a contained defect, I think that there is, like he mentioned, if you clean enough, if you can really, really decontaminate, I think that with the materials that we're using, there's a much